Whenever to start.
Okay, welcome everyone, and thank you for joining us for another session of Virtual Global Spine. Today, I'm beyond honored to host my friend and partner and colleague at Northwestern, Dr. Jean-Paul Wolinsky. He's been with us before. Briefly, Dr. Wolinsky is a master of masters in spinal surgery and a pioneer. He always pushes the field forward, and an educator. So without further ado, Dr. Wolinsky will speak with us about case-based discussion of high cervical pathology.
Thank you, Nader. Hopefully I'll live up to your flattery, maybe not. But so my plan for today, so last time I spoke, we talked about cranioscervical junction and approaches for extradural pathology or extradural ventral pathology of the cranioscervical junction. So today I thought we'll change it up a little bit and do a case-based discussion of high cervical pathology. And I'm going to act as a moderator and pick on our other faculty that are part of this program today. And Ollie will be monitoring sort of what you guys text in or write in the chat room. So if you guys have any comments, you can use Ollie as a voice, and maybe he can say them. And you can even get him to say things that are probably completely wrong, but that's okay, right? Because the part of this discussion is to make it fun, and we learn from saying different things, all right? And we'll try to make it as clear as possible so that we don't lead you guys down the wrong path. So this first case I'm going to show is actually a case that came to me much later, but got a lot of education in it. So this, assuming I can change this slide. So this first case is a 77-year-old gentleman who had an injury from fall from standing. And as you can look at a CT scan, you can see that he has this odontoid fracture and neurologically intact. And so, Nader, since you're the person I can see on my little screen here, what would you do for a gentleman like this? And what were your considerations be as to why you would do these different things?
Okay, you know, we're looking at this sagittal CT of the cranial junction, also at C1 and C2, and you can see here clearly that there's a type 2 odontoid fracture that's not really displaced. It's pretty acceptably aligned. So this, these patients I treat, like they're trauma patients, but usually they're low impact injuries. So I'll put them in a Miami J collar, keep them bed rest initially. I want to get a MRI and MRA to look at the rheumatoid hematoma or look at the ligaments, and also look at the vertebral arteries, carotid arteries, make sure that there's no dissection. And most of the time, these patients, I will end up mobilizing them. I'll get an upright X-ray and see if that fragment would sublux posteriorly. And then I'll go from there. Now, knowing that this patient is an elderly individual, you know, healing of that fracture is probably pretty challenging. But as long as it does not sublux, that can definitely be an opportunity, because I'm one of the believers of fibrous union. Now, certainly, if there's an autofusion of C2 to C3, then definitely that would stress that fracture, makes it more difficult for that fracture to heal, given the loads that it sees. So these are my initial thoughts. I usually end up mobilizing them, look at the alignment, and then go from there with a rigid collar.
Great. Let's just say that for argument's sake, I don't have the pictures on this. I didn't see this gentleman at this point in time, but let's just say for argument's sake that you got the upright x-rays and he does move at C1, 2 from this fracture. And now you're considering what to do. So just for the audience also, I mean, I completely agree with what Nader is saying. And, you know, many times you can mobilize these people, and many times you can avoid an operation because there are definite pitfalls for operating on somebody of this age. But sometimes you're stuck, right? Let's just say that we're in a situation here that, well, at least you're stuck that the collar's not going to do it for him. What are your options then? Or how would you go down this road?
there's like there are many options, in terms of stabilization for this fracture. There's the odontoid screw, 1 or 2 anteriorly, versus a posterior C1, C2, or C1 to C3 fusion, harms fusion with lateral mass screws in C1, pars or pedicle screws in C2. I usually like to go down one more level. I like to stop at C3, but especially if there's a high riding vert. But to me personally, my go-to procedure for these type 2 odontoid fractures that are surgical is a posterior C1 to C2 or C1 to C3 fusion, especially in the elderly.
Right, and that's what I would agree with as well. So this person had an odontoid screw placed, and Ollie, let me see what you. This is actually probably about a month or two after this odontoid screw was placed. What do you think of this X-ray if this person were to come to you in your clinic with this X-ray?
Yeah, thanks, JP. First of all, thanks for joining us again and for presenting cases. So yeah, I mean, I agree with Nader with the initial discussions, DENS or C1, C2. I'm personally, I think like a lot of us maybe did a little bit more in our training, and now we're not staying away from them, but doing a lot less of these DENS screws and really relying more on the probably biomechanically more sound C1, C2 constructs. So if I see, that's just my general overview, my opinion on the topic. But if we see this, I'm starting to, I don't know if that screw was placed proud or it is loosening and is backing out, but I'm not liking what's happening, especially in this elderly patient who not only is probably not fusing, but potentially could have a worsening screw back out and possibly, pharyngeal issues. So I would get a CT and see exactly what's going on. For what it's worth, we're already getting some comments from the audience here. Dr. Selby, one of our panelists, actually also agrees and thinks the odontoid screw is not very favorable in the elderly population. Here he is driving. Hi, Mike. So be safe, my friend. Okay, be careful.
Oh, we're good. I've stopped now.
Right. So Mike, if you could comment on that, because I think that's great. So at least my feeling is I generally am not that excited about an odontoid screw in the elderly, but for the participants, tell us why you think, besides that it's hard to do in your car, but why you think it would be not the best decision.
Yeah. Look, ultimately, the bone quality in the odontoid is often quite poor in these patients, and you're relying on that to get fixation here. And it's a single point of fixation, and people have tried double screws, but I'm not aware of any papers that conclusively prove they're a lot better. So also I think the upper pharyngeal sort of approach for this, although it isn't that tricky, the elderly patients sometimes don't tolerate that upper airway swelling that occurs after this. So it's not a benign approach either. And I know the alternative being a prone instrumentation is still tricky in these older cases, but to me, there's no real advantage for an operation that I've seen fail a lot. And I wouldn't be in a rush to do this in a patient over the age of 70. The exception being someone with excellent bone quality. And then you've got to have an informed consent discussion. But my center, we're very conservative with these because we've seen a lot of failures with operative management in the past. And we really go benign neglect almost for a lot of the older patients, particularly those above 75 that are a low functional demand.
Yeah. So this was initially, look, I don't know what the original post-op films looked like. My assumption is that they put the screw in flush, but who knows? But this is 1 month after surgery, and then they decided to follow this a little bit longer, and this is now 2 months out from surgery. So Mike, you probably, I don't know, you've got a phone, so you may or not be able to see this well, I don't know. But Mike or Ollie or Nader, why don't you comment on this odontoid screw, and besides the fact that this person's 77, what are other reasons why this person, and the bone quality might be poor, what are other reasons why this screw might fail? Technical issues maybe with the screw.
I mean, the entry point is a little anterior. It should be a little caudal, like it should be at the bottom of the end plate of C2 to place it. You know, it's just that's your entry, but right there. I mean, this is like it's like through the anterior cortex of C2 vertebral body. It should be like the entry point, the trajectory. It's should be a little bit different. It should be more less acute than this.
Right. So for the participants, when you're placing one of these odontoid screws, you know, this is probably one of the most overtaught procedure and under-needed procedure, but it is a good operation in the younger patient that you want to maintain mobility. But if you're going to do it, you need to do it right. And like Nader said, is if this is the anterior cortex of C2, this is the inferior cortex or the end plate of C2, you really want to enter through the end plate. So in order to get that trajectory, you need to make a little trough within the C3 vertebral body so that you're coming along this angle. This screw came through the anterior cortex of the vertebral body. And so that by itself is going to be biomechanically not as sound as if you're coming from below. The other key is that you need to make sure this is a bicortical screw so that you can get fixation, very strong fixation at the other end. This is the CT. Let's see if I can pull this up. This is the CT that they had. So they actually had the fragment nicely aligned, but you can see the actually lucency around the screw and it's been slowly coming out, right? I think I have one more picture, yeah. So now, Ali, you've adopted this patient now 2.5 months out from their injury. He's 77 plus 2.5 months old. Bone quality is about the same. He's got a little bit of dysphagia, nothing horrible. Been the same after surgery, but he's got bad neck pain and the screw is certain to fail. What are your thoughts now about what you want to do?
Yeah, I mean, boy, so it's funny how it goes, right? When you showed me that first, I guess X-ray or CAT scan, that one, right? Yep, that one. When you first showed me that, you know, to me that's early failure. I probably, you know, would have left the front alone and just did the C1, C2 and called it a day. Now that he's several months out, possibly going back to Nader's fibrous non-union, you know, a comment, which I fully agree with. Now I feel I'm obligated to take this out. And to be honest with you, I have no problem, based on the CAT scan you showed me, I have no problem taking this out, keeping the patient in a collar for a few weeks and getting a delayed flexion extension instead of taking it out and committing him to posterior C1, C2.
All right, I think it's very reasonable. So this patient actually—
And I'm interested in seeing what the other participants in the
Mike,
chat box. If anybody wants to put in what they would do, I'd love to see what the participants in the audience would do for this.
Yeah, Ali and JP, I would look at if I was taking it out, I'd probably just go straight to the back under the same anesthetic. You know, this patient's had one surgery. You know, I'm not convinced it's united completely when it's backed out. I know the alignment's good, but I think if you've committed to fixing this patient, you should finish it. But I recognize that you know, there's no right answer here. But I'd probably give him one anesthetic, take that out, and as long as that wasn't particularly complicated, removing that, there were no pharyngeal tears, etc., then flip him and do the rest. But you do this one is where they're backing out a bit. It can be a bit tricky, and it might be one to get the ENT surgeon to give you a little hand with the dissection on.
Yeah. I mean, I probably would leave it alone and just do the posterior fusion, C1 to C3, and then tell him, you know, if he doesn't have dysphagia or like worsening dysphagia, because I don't want to create one. I mean, it's controversial, but I don't know. It definitely has backed out significantly in the interim.
So the story does not end here, and he still hasn't come to me yet. But then, so he had the screw taken out, and then a posterior fixation infusions. If you look at actually of the, you know, to Mike's point, if you look at the alignment of the odontoid and the C2, after that screw is taken out, it looks like it's changed a bit, right? So it probably wasn't as stable as you would hope, even after that time period. But they did a C1, C2 fusion with C1 lateral mass screws and C2 interlaminar screws or translaminar screws, however you want to refer to them. And here's the C1 lateral mass screw on one side. Here's it on the other side. Here's it on the CT on the coronal. There's in the axial. That's the C1 screws. Here's an angio, and the left foot doesn't fill. And then here's your interlaminar screws. So I can go back through them, but what are your thoughts now about this guy? Now he's actually in your clinic. They've kicked it down the road.
Well, not good. I mean, definitely there's screw misplacement, two of them at least. The left-sided, well, both left-sided actually, because the translaminar screw, you start on the right side and it ends on the left side. That are no bony purchase. And one of the screw, the lateral mass screw, I would think, of C1 has caused a vert injury. Luckily, didn't cause a stroke, or maybe caused a small stroke, but no one knows about it, like a minor cerebellar stroke that no one knows about. But that does not look good. Needs to be revised. Now that it needs to be revised, and I think the other translaminar screw is not fully into the lamina, right? It's backing out a little bit. I don't know. I mean, that's one cut. Maybe there's.
I think it's actually either it wasn't fully in or it fractured out. So they probably went in and then they didn't save enough space for that other screw and pulled out. So Ali, I mean, it's been a long time since we've worked actually physically together, but I think when we worked together, you did a bunch of these. I've mostly moved away from doing them just because I think they're fairly proud on skinny people, but they can be a good screw. What for the participants, what's sort of the key concepts that you want to think about when you're placing these translaminar, or probably better term is interlaminar screws?
Yeah, JP. First of all, my first question is what's going on in Chicago? I mean, who is this Notter's patient, or what's going on up there, guys?
This one I actually saw when I was at Hopkins. So this was somewhere on the East Coast.
Probably one of the fellows cases, right, from back in the day.
Yeah, no, I don't think so. This was I don't think it was actually local to Baltimore. I think it came from New York, New Jersey. So I don't know, whatever, somewhere.
Yeah, no. It's listen. These things happen. I mean, they're not easy. And I have a few slides on high cervical. Actually, we're talking about that next week. Next week, we're doing another high cervical CVJ session. So a couple of things. You want to be, I don't know if they use navigation or not, but you want to be, I love navigation. You want to be careful with navigation in in this OC junction, because sometimes the hypermobility of C1, C2 can really get you off. So I've actually seen more of this with navigation than not. So just as a caveat, I like translaminar screws. I've been using them a lot when I do, say, complex cervical deformity or kyphosis. After I do lateral mass screws or pedicle screws at C2 or C1 respectively down to the thoracic spine, I love to drop a third rod down separately, C2 translaminar down with a third rod into, and then domino it with one of the rods into the high thoracic spine. So that's really what I've been using translaminar screws for. I don't use them as my primary points of fixation if I'm doing a C1 to C3 or C1, C2. But they tend to be very safe. They have robust fixation. Sometimes it's hard to connect them just because of the trajectory, and that's why I just drop a third rod altogether and not worry about connecting them to the the other screws. But yeah, I mean, I like them. They tend to have really good fixation, points. I think it's just obviously something happened here, but I think they're good fixation points.
Yeah, so I would agree. So I think they're generally fairly safe screws. You can actually get fairly long ones. I think on average, a translaminar screw would be about a 32 millimeter screw. So you can get a fairly long screw. They're fairly safe because the vertebral artery is not at risk with these screws at all. The key is that you have to have a big enough lamina for them, and they usually do. And the other key is that you have to save space for both screws. So the first screw is usually the easiest screw. Most people make the mistake of putting it right in the middle of that lamina, and then they use all the space for the other screws, so you can't cross them well. And that might have happened here, and that might have been what forced that other screw to not get good purchase. So put one of the screws rostral and the other one caudal within one another. It's hard to describe that on the computer, but so that you can crisscross each other and make enough space for these screws to pass each other. And making sure that they're long. I usually use a tap to find that way down that space if I'm going to put one of these types of screws there. So there you have it. So we have these two bad screws, that C1 lateral mass screw in the vert, and this one of these bad interlaminar screws. Nader, I think, was voting for revising this. How would you revise it, Nader?
I look at the pars, pedicles, make sure that we can get good purchase there. And I will revise the C2 screws, both of them.
I don't think I have good pictures of the pedicles, unfortunately. Sorry for that.
Yeah, I mean, it just needs to be, we need to make sure that it's feasible to instrument C2. I'll instrument C1 again. I mean, on the left side, the right sided screw, I won't touch it because it's in an okay position. And I'll go 1 or 2 levels below. I try to stay away from the occiput as much as I can. And I'll, these are my initial thoughts, but you need to look at the scans, the sagittals, parasagittals, and then see. But I would revise this.
Now, Nader, I'm going to be devil's advocate here. So on the previous slide or two, I think one side is okay, right? The right C1 lateral mass, is it, that looks okay?
Yeah.
Maybe barely in there.
No, it looks
this
good.
one. So
this
you've got, you've got this C1 lateral mass screw that looks reasonable. You've got one translaminar screw that looks, or interlaminar screw that looks okay. What do you think of just watching him? I mean, again, trust me, I'm pro surgery, but we keep getting in trouble with this guy. And what's wrong with just watching him with the current fixation and seeing how he does?
It's certainly an option, Ali. I mean, to be honest, always, like when I see patients, I don't give them one option. I give them options with pros and cons of each. Definitely, we don't treat the image, we treat the patient too, and we need to, make sure they're well counseled. Now, the question is, what are the goals of surgery if we do it? The goals of surgery is to achieve the prior goals of placing these screws in the right position, at least first and foremost, and then achieving a fusion, at least across the fractured fragment. But certainly,
but a technical question on that, Nader, you're not going to remove that left C1 screw, are you? The one that's in the foramen? Are you? I mean, right? So when you think about revising it, you'd leave it alone and just go above and below, because I wouldn't take that screw out, right?
I think taking that screw out could be risky.
I mean, it could be risky, but what's the risk? The vert is out.
It's out on the angio, but it might bleed when you pull that thing out, right? It might be blocking that thing from bleeding.
Right. Yeah. Correct.
It could be exciting.
It could be exciting, but
it could not be. It might not be. And then then let's just say you pull it out. If you're going to pull it out, what kind of safety measures are you going to have for yourself? Just because this, sometimes this happens acutely, right? Where you have to make these kind of decisions.
Yeah.
Luckily, this person's in your clinic, so you could still punt this person down the road. But let's just say you're in the operating room, and let's say that one screw is in the vert, or you're concerned that it's in the vert. How would you go about pulling it out or leaving it?
I need to think about it, but I'll definitely instrument everything else, and then make sure I notify my vascular.
How would you instrument
surgeons.
Everything else? What would
do a
C1 lateral mass screw next to that one?
So there's a lateral mass screw and C1 on the right side, and then I'll instrument the. I need to think about it. Yep, I'll probably put this, if I can, put that lateral mass screw on the left side. Yeah, yes, it's not that straightforward. I mean, I'll pull it out, and then if there's no bleeding, I'll proceed with putting a new screw. If there's bleeding, then it's a different story, but I'll definitely have my colleagues from vascular notified to help out. The guy has a stroke, it's already out. You can control the bleeding. I mean, it's not going to be an impossible bleeding to control, to be honest. I mean, you can certainly control it, and then do an angio. But yeah, I mean, I think the damage has been done already. You know, that's my thought process.
Yeah. So I was a bit concerned about this as well, just like Ali, and I do agree with what Mike was saying earlier about, if you're going to take out that odontoid screw, I would turn him over and do the other operation. But at this point, I think that maybe leaving him in a collar longer with that poor instrumentation on one side might be the right thing to do. Now, you could be looking at a bigger failure if those screws loosen up on that right side, and then you have to revise things. If I were to revise this, I'd be a little bit hesitant about pulling out that screw, because I think that you can get control of it, and there's no worry about having to sacrifice that vertebral artery. But sometimes in that little deep hole, it can be a problem of actually getting real control for the long term. You can pack it and try to dissect it out above the arch, and then you have to try to find it out where it comes out of C2, and you can do that. But that might be a lot for a 77-year-old person, right? If you don't need to. And I think if I were to revise this, I would probably go to one of our older screws and do a transarticular screw. And you don't really actually have to worry about the pedicle on that side, because the vert's already out. So you have a freebie, right? You can just shoot a screw right on through there, through the C2 pedicle up into the C1 lateral mass from below, and link that up. Now, it's going to be a complex link because you have this lateral mass screw on the right-hand side that's good, and you have the interlaminar screw coming from the left-hand side that's going into the right, that somehow you're going to have to crisscross with your rods. But I think all that's possible. But I think for this, I would probably observe them. Mike, what do you think? Would you observe or revise?
I'd probably observe at this point, just because there's a fair amount of bone graft there, and I'm not sure if these screws are out acutely. So if they were placed this way, or they've kind of windshield wiped their way out, there seems to be a bit of a halo effect, at least around that laminar screw. And, when you do this open exposure, they've put this bone graft down there. You would have hoped they would have noticed the tip of that left laminar screw out of the lamina. So to me, it's kind of failed at some point, and probably not in their index surgery that it was really right out. So I would, I'd observe, put in a collar for a while. A handy trick to get rid of a screw that's near a vert. They're so pathetic, these 3.5 screws in the shank. You can usually just get a rod cutter on there and just cut it straight off. If there's enough space in a big revision, you don't have to take the whole screw out. You can leave the metal part in there, tamponading the vert, and just cut the head off if it's going to get in the way of a TA screw. But JP, I agree, TA screw is a good idea if you have to revise. But I'd hold on, do a CT in a couple of months and see how he goes.
Great. So let's, I think we beat that guy to the death, 30 minutes for that case. But let's get another one. A very similar sort of thing, but this is, we'll make him a little bit younger. I think he's probably in his 50s. History of renal cell carcinoma, comes in with acute onset neck pain, no fall, no trauma. And he has a CT scan. And then here's we were looking for your pedicles and pars, C2 for your left and right. And here's your MRI scan. Oops, sorry. And this is what your C2 looks like there. So with this kind of thing, Ollie, what would you think about? Metastatic renal cell to the cervical spine, maybe, or at least a fracture in that region without significant trauma?
Yeah, I mean, obviously not a benign looking CT at all. I'm worried about the angulation. I'm worried about the splaying of the posterior elements. Do we have an MRI, JP?
Yeah. I don't have a T2, but that's your T1.
Mm-hmm. Okay.
With contrast.
Yeah, I think if the patient, from a medical perspective and an oncological perspective, is stable, I think they need stabilization across those levels. I didn't get a chance to look at C1. Is this something that
C1 looks reasonably okay. He looks a little bit osteopenic, but not horrific.
And the mid-sagittal again, please. Yeah, this is somebody that I'd feel more comfortable in fixing surgically, and if C1 looks good, which it does based on images we saw, I would put this patient in intraoperative traction, light traction, and do a C1 to C3 or even C1 to C4, depending on the quality of the bone.
Yeah. Any thoughts of going to the head or benefits,
I mean,
downsides?
I mean, listen, I'm in the minority here because I probably have done and do more OC fusions than a lot of people for different reasons. But I like OC fusions. I think they're not as morbid as we once thought they were. And I'm very liberal with doing OC fusions, especially in elderly patients who have really, lost a lot of their range of motion due to arthritis and whatnot. But again, if I don't need to, and if C1 is intact and which it looks like it is here, I have no problem doing C1 to C3 or C1 to C4.
Yeah.
Yeah.
Nader?
I mean, this is, I actually treated a few patients like this, and this is like, I think to me, this looks like a pathologic fracture of C2 and then causing a C1, C2 subluxation. You can see the lateral masses of C1 subluxing forward relative to the facets of C2. So, as Ali mentioned, you got to definitely check the boxes, talk to the oncologist and get a feel of the prognosis. You want to make sure that this person is gonna survive at least 6 months. And then, he has reasonable Karnofsky score. My concern with that is the osteopenia / osteoporosis. So what I would do, this is a deformity of the CVJ. I would put the patient in traction and get them realigned. This should realign easily with maybe 15 pounds of traction. I would lock them in a vest and then perform C1 to C3 or C4 fusion, but a low threshold to go to the occiput on this one. I think my feeling, I would definitely consider going to the occiput, or there's a low threshold of going to the occiput and maybe an occiput to C4, given the bone quality first, because you want to get good fixation points. I don't trust too much the lateral mass screws in the face of such subluxation and poor bone quality. So, but I'll put him in traction, lock him in a vest. It will reduce perfectly. Get a CT scan, make sure that everything looks good, and then do a posterior fusion, occiput to C4 versus C1 to C4, something like that.
I agree. So what was done here, I think, was a C1 to C4 and realignment in the operating room. And this is a postoperative CT scan. I spared the head mostly just because it allows you to maintain some motion there and less strain for the patient. All right. So this is another interesting little fracture pattern that we see not as commonly. The gentleman fall from standing, neck pain, and looking at this.
JP, sorry to interrupt.
Yeah.
Just a question from Dr. Jara, one of the participants. Why not transarticular C1, C2 in that last case? And honestly, he brings up a good point. In general, I think a lot of us are obviously not doing C1, C2 transarticular. In my training, I probably did it once. I know that folks used to do it a lot more often. Can I just get your thoughts on that C1, C2 articular screw?
So I love the transarticular screws. I think they're a great screw. They're number one, they're not very expensive. I think each screw is about $25 each. Somehow the trauma sets haven't figured out how to charge as much as the spine sets. So especially if you're doing things outside the United States, it can be a very good solution for many patients. Technically, it's a little bit harder to do than the other screws. And one of the other things for something like this is that you need to have the person realigned before you place that screw. So you can't use the instrumentation itself to do the reduction of the deformity. So one of the powers of a C1 lateral mass screw or even occipital instrumentation is that there's a lot of power that comes with that to reduce a fracture like this. So if you were to do the transarticular screw, you really need to realign them either in traction like Ali was suggesting, or like Nader was suggesting, putting them in a halo preoperatively and making sure that they're aligned well. because when you fire that screw, that's the alignment you have, and it's very hard to reduce them otherwise. You can do maneuvers where you move the head, you can push on the cervical spine while you're placing that screw to get that to go, but it is technically more difficult. The other thing about it is that in this patient, I actually, even though I love a C2 pedicle screw, this is one that I probably wouldn't put a C2 pedicle screw in just because of the oncologic nature of C2, and that bone's probably not going to be the strongest bone to hold that screw. And if it's a C2 transarticular screw, goes through that same bony corridor, and you have to have that same bony corridor to hold that. And so probably from my perspective, from a durability perspective, I think you're better off skipping the C2 level and going down to 3 and 4. But if you realign this, you could do a transarticular screw, I think.
Thanks for that, JP. And just another follow-up question.
Yeah.
Did you reduce that fracture in traction or in Mayfield, or using the instrumentation? I apologize. I think you just mentioned it, but somebody wanted to know exactly what your technique to reducing that fracture.
I usually use the instrumentation to reduce it, or even just positioning them in the operating room. It's one of these things that after you do enough of these, you realize what you can get away with intraoperative traction or just with reduction with the Mayfield. You have to be very careful with these fractures because these people are wildly unstable compared to, say, our C1-2 subluxations from rheumatoid or ligamentous laxity. But with a fracture like this, you can realign them. One of the keys, though, is that when you're realigning them, you need to consider, am I going from C1 down or am I going from the head down? Because if you're going occiput to cervical, you want to make sure that your alignment of your head and your cervical spine is right, because that's the spot they're going to be stuck in forever. And if you have them looking up at the sky or looking down at their toes, particularly looking down at their toes, some people will do this by accident because they think it's a better way to get in to see their other instrumentation. That's how they're going to be locked in forever, and they're going to hate you. Number one, if they're looking at their toes, they have trouble walking, right? Because they can't see in front of them. And if they're looking at the sky, they hate you because they can't eat and they can't read, right? And so you want to have them in a nice neutral position. And that limits what you can do to a certain degree with your intraoperative traction, things like that, as far as reducing things. But you can use the instrumentation to reduce them. If you're doing a C1 to C2 or C1 to C3, whichever construct you're deciding, there I want to actually tuck their neck a little bit because I want to get that space between C1 and C2 to open up so I can get my screw into the lateral mass of C1 without having to cut the C2 nerve root. It's not a big deal to cut the C2 nerve root, but I like to preserve it because I think it tells me if the patient develops a pseudoarthrosis later by developing pain in that C2 distribution. And if you have them too much looking up, then you're going to close that space off and you're not going to be able to get in there. But if you position them like that, then they can compensate at the occiput cervical or OC1 junction. That answer things?
Got it. Yeah, no, absolutely. And again, I apologize, but one last question. I know you got great cases, but
no, keep going.
You do a lot of, obviously you're phenomenal with oncology. And when do you, it's a little bit off topic, but what are your thoughts on cement augmentation for C2 pathologic fractures, whether, without instrumentation, in addition to instrumentation? You've seen these, whether it's lymphoma or myeloma, or, you see these C2 fractures, they're like, boy, if this was anywhere else, I'd love to put cement in there. What are your thoughts on C2 cement augmentation?
So I've cemented a couple of these, or I personally haven't. I've had my radiologist cement a couple of these where we've been concerned of them potentially fracturing in the future if we're going to give them radiation therapy, where we're trying to just get them through without having to do an operation. If they've already fractured, I think that the cement is probably not going to be helpful for them, and you're just kidding yourself and probably putting them at risk. But if you're worried about them fracturing, let's say the CT looked like this one on the right, without, of course, the instrumentation, but where you see this kind of ratty bone, but they don't have a fracture per se yet, where they're still stable there, those probably reasonable to cement before you radiate. Because once you radiate that, and let's say it's renal cell carcinoma like this one, and you did stereotactic radiosurgery to that, it's certainly going to break. And so if you're trying to avoid an operation, somebody like that, because maybe they're too frail for an operation, it's probably pretty reasonable. I have also seen, patients where, even though I think you're right, Ali, I think that we've gotten much better with our OC fusions and patients tolerate them pretty well. But if you can get away with not going to the head, people like it even more, right? If they're stuck, they're okay with it. They're happy with it. But if they can have that mobility, they're very happy too. And so I have seen a handful of patients where I've done cement augmentation of the C1 lateral mass screws, where they've got tumor in that area. And I just couldn't mentally commit myself to going to the head just because of that C2 problem. And I did cement augment the C1 lateral masses to get away with the C1 to 3 instrumentation. But that might be sort of fringy, or I would say that.
Got it. Thank you.
One more last thought, JP.
Yeah.
I mean, the thing is, like, to me, I treat like fractures and degen a little bit differently than metastasis. Like stage 4 mets, you want to try to operate on this patient once, as much as you can, right? Like,
yeah.
So that's why my threshold a little bit is in the face of poor bone quality is just to do a bit more, like going to the occiput, as opposed to someone else, like with obviously a rheumatoid patient, you want to do a C1, C2 fusion. But this person, what if this fails? You're gonna bring them back and take to the occiput, correct? I mean, that's
right. I mean, that's the thing. It's right. Yeah, there is a mantra that we have at Tumor, and that's go big or go home, right? And so, but at the same time, sometimes you go to the head and it pulls out of the head too. So there's no, unfortunately, there's no 100%
no panacea.
perfect experience. And so, for me, putting a C1 lateral mass screws, I always go bicortical as well. And so, you really actually get a great screw in C1 if you're going bicortical. All right. So we don't use up all your time with just 2 cases. This one, so this is a guy, fall from standing, neck pain. Based on what Nader was saying for the first case, or whichever that case was, some of these elderly odontoid fractures we can place in a collar and they'll get a nice stable pseudoarthrosis. Nader, when you look at this guy's CT scan in particular, looks pretty nicely aligned, right? Is this somebody you think can get away with a collar, or is there something special about this guy?
There's something special, he has, I think, a C2, C3 autofusion. So it's like having an adjacent segment disease, right? Like it's unstable above a fused level. So that decreases the chances of first stability and second fusion, right? Like it's a bit ankylosed. It looks arthritic. So I'll look at the joints. I'll even look at at the occiput C1 joint too and see what's going on there. But it looks aligned. But I would definitely start mobilizing him with a brace. But I'll be careful about that fragment subluxing posteriorly when he stands up or she stands up.
Yeah, Ali, what do you think?
Yeah, I agree with Nader. I put in the chat box, to me, this looks like an Ankh spondy light. You know what I mean? It's like not really Ankh spondy, but boy, there's a lot of kind of ossification in the disc space. There's some autofusion. So outside of that, I think this is, this is the case where you kind of put them in a collar and you watch them. I will say one thing though, and we do have several trainees with us and research fellows and even some students. The one thing I do, whether it's these fractures or any fractures, but especially these fractures, if I'm going to put them in a collar and see if that's okay, I'll definitely get an upright AP lateral open mouth view before they leave the ER. Because, yes, they may become unstable in 2 or 3 weeks, or they may sublux, but I'd like to know what they look like before they even leave the ER, because sometimes they fail right there. But despite all of that, I wouldn't mind putting this patient in a collar and getting an upright X-ray, AP lateral open mouth, and maybe doing, and if the alignment is perfect, do a short follow-up, maybe another X-ray in about 3 to 4 weeks. If initially on the upright X-rays they're already slipping and sliding, then I'm probably going to commit them to surgery sooner than later.
Yeah,
You
I
know,
mean, this guy makes me pretty nervous. And the reason why I say that, and you know, I might have the benefit of having the screen in front of me and having seen a lot more of his films, but I do think he's ankylosed throughout his spine. And if you look at that odontoid fracture, he has a fracture here. And normally, obviously, our C1 and C2 lamina don't articulate, but here it looks like there's actually a fracture through that ankylosed part in the back. And to me, these people just, you know, he might heal, right? Just like any other ankylosing spondylitis fracture might heal, but he could also go south super fast. And so I think I didn't take a chance on this guy. I don't think I have any films of what he did, but right. So I'm going to skip this just because of time. Here's a good case. So this, keeping our same theme of old people with fractures. Here's a 70-year-old gentleman, comes in with a fall. He has this fracture, except for the difference with him is he's an incomplete quad, and he's intubated, and he's was hypotensive, and he's being maintained on 3 pressors to keep his blood pressure somewhat reasonable, maps of 70 even, okay? So Mike or Ali or Nader, how would you manage this guy? So hemodynamically not the most stable, old, incomplete quad.
JP, this is a tough case, and I've seen this all too many times. But you know, when you have an incomplete injury and you're an elderly patient with a type 2 fracture, I found the chance of making it out of hospital or making a recovery are not that great. And yeah, I think what I've done, some of these patients though are remarkably tough, and I reckon this is probably a cause of death in a number of people. May not get picked up. You know, elderly people fall over, they have this injury, and they get a high cord injury, stop breathing, and pass on. So to me, what I do with these patients, I give them a little trial of life in the ICU, and I put them in some gentle traction and see if we can realign them. And then if they're going okay after a few days, then I will look at fixation. But I find a bit of traction actually helps to immediately realign, get a bit of pressure off the cord. And sometimes they bounce back and they actually show signs that they're going to potentially do okay. And others of them will go downhill rapidly, even in traction. And they're the ones that probably need to be palliated, to be brutally honest. And so I'd start with some gentle traction in the ICU for me here. After an MR, I mean, yeah.
So Mike, for your for the participants, what would gentle traction mean?
Look, we use kilograms, not pounds, but
that's
no,
right. We probably can do math here. We'll figure it out.
No, I'll go to pound. I'd start with about 10 pounds and potentially go up to 15 to 20.
Here's 10.
Yeah, beautiful.
Go more or stay at 10?
He's realigned a little. I mean, the MR the only concern would be whether he's got an injury at the OC ligaments. But I'd probably go up a little more with that. But the other thing is this patient has a naturally hyperlordotic neck.
Here's 20.
And so you need to really get that roll in. A little better, still a little off, not as bad as the initial CT. Did you go a little higher?
It's 30.
Going to 30. Yeah, getting still, it's not really fixed. It's not really changing between 20 and 30. And yeah, it makes me just wonder 2 things. One, well, traction may not work here. And the second thing is, with that very hyperlordotic cervical spine, is that the patient's natural state is perhaps not being replicated here with traction, and whether you need to change the angle slightly. And I wouldn't keep going up and up though, not after 30, not me.
Nader?
Yeah, I mean, the thing is, like, as Mike alluded to, I mean, he has upper thoracic kyphosis compensating with hypercervical lordosis. So it's subluxing posteriorly with that fragment because of his really high. That's why sometimes with these patients, you don't want to keep their head hanging. You want to maintain spinal precautions, but you want to bolster the head. You want to make sure that there's the gap between the head and the bed is filled, because otherwise they'll sublux even more because of the thoracic kyphosis, cervical hyperlordosis. So certainly, you know, Usually the occiput C1 joint is okay as long as the condyle C1 index is low. That you wouldn't be worried about going up with traction. But 30 is pretty on the higher side. I would certainly, I like to use the crown halo traction so that I can make some adjustments. Distract and then flexion. You know what I mean? He needs to go anteriorly. He should be translated anteriorly. So I want to play with that first before I go up with the traction pounds. I may even put them in a vest and try to kind of move those poles anteriorly, try to play around with it to try to realign it this way, because it should realign better than this. It should with traction and manipulation in terms of the vector forces.
Yeah, I agree. And sometimes you can play with things to make them go more. I added more weight. It's 40.
Yeah.
And then they popped over.
Excellent.
So, and then we were able to ride him out a little bit, and he stabilized more neurologically, actually made some improvements, and also got off of his hypotensive medication. So we were able to get an OR and stabilize him posteriorly. But I think, this case is really just to summarize sort of things that you don't necessarily need to go directly to the OR. I mean, we always want to, right? Because it's somewhat easier to control things. But, one of the things that we got to keep in our recipe book is really traction, because traction is the fastest way you can really reduce somebody, as long as the only contraindication, as Mike said, is if you have incompetence between the occiput and C1, between the condyles and C1, where you're going to pull the head off. But otherwise, they tend to have pretty strong ligaments. And these people that have odontoid fractures, although we always look for it on MRI scans, we always look for transverse ligament injuries. It's pretty rare, because the first thing that happens is the bone breaks and the ligament stays, or the ligament avulses and the bone doesn't break, right? So one of the two things is going to happen. It's pretty rare for both to happen. And so then traction is a possibility if the ligaments are intact. All right, let's see what kind of time. So we have just 6 minutes. Now, should we just wrap it up, or do you want to go for another case, or how should we move things with?
I think I'm up for another quick case, obviously. But the end of the saga here, you went to OC or you stopped at C1? What?
C1-2.
C1-2. Okay. Yeah, let's do a quick case, maybe, JP. I think it's good. 6 more minutes. Let's just fill it.
Yeah, here's the final.
Beautiful.
Okay. So let's see. Let's get that one. So this is a good one here. This is a patient who was sent to me for evaluation. They said that this guy, I think it's a guy. I don't remember. I don't think it shows anywhere here on this guy has an Mensingioma at the craniocervical junction. And they didn't want to take care of it. They thought that it'd be best to kick it down the street. So what do you guys think of this?
Okay, quickly. I see that he has a retroadontoid pannus or lesion, and I'm looking at the ADI here roughly. It's a bit elevated, I think, just looking at the MR, but certainly I get a CT scan. So if there is a concern of...
And this is the contrasted MRI scan on the left, non-contrasted T1 on the right.
So it does not enhance, so that increases likelihood of a retroodontoid pannus, but or collection. So I will get a CT scan. I will get an X-ray too, and then look at those.
Actually, I don't have them, but on your X-ray and your CT scan, actually the ADI doesn't look to be significant, which, sometimes these retroodontoid pannuses, you don't really see a change in the ADI, mostly because these people have such bad spinal cord or brainstem compression that they just hold their neck rigidly as possible. So they don't necessarily sublux, but they do have a little bit of a change in their ADI.
And I'll run it by the radiologist.
What about the thoughts that that the other neurosurgeon that sent the patient in the first place had about this being meningioma?
it does not enhance. I mean, I'll talk to a radiologist too, but it does not enhance. Meningioma should enhance a little bit. It doesn't look to me like a meningioma, to be honest.
Right, I agree. And so,
and there's some erosion into the C2 dens too. There's some erosive there. It looks more degenerative and like a pannus or something like that. But I will talk to a radiologist about it too, for sure.
Great. And so, just for time's sake, since I think we only have about 2 minutes left, how would you treat this?
This is a philosophy, I mean, a retroodontoid pannus to me means that it results from instability. So I would not go from the front. I would do a posterior. I'll do occipital cervical fusion. Atul Gowal will do a C1 C2 fusion, and he wouldn't do a decompression, and the lesion would disappear. I usually like to decompress, because in the acute phase, if the patient had an acute worsening of his symptoms, at least I'll show an MR would show a decompression posteriorly, that there's room around the upper cervical spine. But I would treat it a posterior decompression infusion. I would not go chase after the lesion anteriorly.
Yeah. So early in my practice, I probably would have done OC fusion as well. And as I sort of became more and more comfortable with it, looking at the OC1 joints, as long as that looked fine, which majority of the cases they do, then I would do a C1 to 3 or a C1 to 2 fusion. But I completely agree that in my hands, I always do a C1 laminectomy, if not C1, C2 laminectomy, to give that patient immediate space. Because I feel that, if they're already myelopathic, even though these things can resolve surprisingly quickly, they can disappear in 6 weeks or so, but it still takes some time. And I think that the laminectomy itself, as long as you're not putting instruments underneath the lamina to resect that lamina, it's a very safe operation, right? Yeah. All right, so why don't we conclude there? And Ali, I don't know if you have some closing remarks or not, or...
Beautiful cases, JP. Thank you so much for sharing those and your wisdom. I learned so much. I learn personally from you so much every day. And on to the next session. Ali will be hosting the next session. So Ali, you want to tell the audience what you want to speak about?
Yeah, absolutely. Thank you, JP, for these cases. And it's a great segue to next week, which is a continuation of this theme. Actually, Dr. Dadale and I and some other panelists and faculty were going to put together some CVJ cases. So more pathologies, trauma, tumors of the occipital cervical junction. So it'd be a good segue for that. And yeah, we're looking forward to that. Thank you, JP. Great to have you with us again. And thank you to our participants and to Dr. Dadale for another great guest and terrific job hosting.
Great. Thank you very much. You guys have a great week.
All right.